I'm Mel Akerman.
I'm Carla Pecoraro.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG. Today we're talking about our next infection in our antenatal serology screen, hepatitis C.
Did you know that hepatitis C was only discovered in 1989?
Wait, what? No way.
It's true. So we knew about hepatitis A and hepatitis B, but there was still this cohort of people developing cirrhosis and liver failure, especially after receiving blood transfusions. Scientists couldn't work out what was causing this hepatitis, but they knew it wasn't caused by Hep A or Hep B, so they literally called it non-A, non-B hepatitis. It wasn't until 1989 that a group of American scientists were actually able to identify the virus, and naturally they called it hepatitis C.
Wow. So what is hepatitis C?
Hepatitis C is a single-stranded RNA virus. This basically means that the virus carries the instructions for making new virus particles in its genome. A person usually becomes infected with hepatitis C after being exposed to contaminated blood. The virus enters the bloodstream and preferentially infects hepatocytes in the liver. The virus enters the liver cells and then uses that cell's machinery to make more of itself. Bulk virus then gets released back into the bloodstream, which allows it to infect even more cells. During this process, the liver cells get damaged, leading to abnormal liver function and inflammation, which, if left untreated, can progress to liver failure, cirrhosis, or hepatocellular carcinoma.
So is it just the liver that gets affected by hepatitis C?
Well, actually, no. Hepatitis C can also affect the immune cells, endothelial cells, fibroblasts, and even the nerves and brain. Some of these effects are due to the formation of immune complexes, but the primary liver dysfunction that occurs with Hep C is due to actual infection of the liver cells.
Now, we've mentioned that hepatitis C is transmitted by blood. Can we talk a bit more about this?
Well, like you've said, Hep C is a blood-borne infection, so the majority of cases of transmission are from infected blood entering the circulation. Hep C is considered to be a flavivirus, and it falls into the same category as some other blood-borne infections like dengue fever and Zika virus. The difference with Hep C is that it's not vector-based, meaning it can't get spread from person to person by mosquitoes. Transmission of Hep C mainly occurs from shared needles or from blood transfusion. Now, blood transfusion is extremely safe nowadays. But as recently as the 1970s and 1980s, blood transfusion was a major cause of transmission of blood-borne infections. We didn't start screening blood products for Hep B until 1970, HIV in 1985, and Hep C in the 1990s. In fact, in some developing countries, blood products still aren't screened for these infections, and so blood transfusion continues to be one of the biggest causes of Hep C transmission in those countries. In the developed world, IV drug use tends to be the most common cause of Hep C transmission. In fact, there's about a 60 to 80% prevalence of Hep C amongst drug users. Shared needles with IV drug use or unsterilized tattoo needles are common causes of transmission, and this frequently occurs in prisons, with about 50% of prison inmates sharing unsterilized tattoo equipment. Most licensed tattoo facilities have very good sterilization techniques, and so it's quite rare to get Hep C from a tattoo if you get it done properly.
What about needle stick injuries? Like if you're trying to cannulate a patient with Hep C and accidentally stab yourself with a needle. What's the likelihood of somebody actually getting hepatitis C from a needle stick injury?
Now, this is a terrifying situation that no one wants to be in. We've all had needle stick injuries and ended up waiting in ED to get our screening bloods done. Fortunately, most of the time our patients have had their antenatal serology, so we know how worried we should be. But for those times when you've got your needle stick injury from a patient with hepatitis C, it can be really nerve-wracking. The actual risk of contracting hepatitis C from a needle stick injury from a hepatitis C positive patient is at about 1 to 3%. A blood splash to mucous membranes is less likely to lead to infection.
I have some awful stories of the spread of Hep C, which might help remind you of how this infection is transmitted. First, there's this evil German doctor who infected over 200 patients intentionally with hepatitis C. This doctor had Hep C and was an opioid addict, and so what he would do was inject himself with opioids and then use that same needle to inject the patients with their anesthetic. There's actually also a Melbourne anaesthetist who did the same thing and was convicted in the early 2000s. I think it was 2013, actually. He was also an opioid addict and injected himself and then 55 women attending an abortion clinic. Thankfully, both of these monsters were caught and are now in jail. Then there's this whole situation in Egypt. So Egypt had this huge schistosomiasis problem. You might have heard of schistosomiasis. It's that parasitic worm that lives in the water and it gets into your skin, then your lungs and your liver and causes all sorts of health problems. Well, this was a huge issue in Egypt. And in the 1950s to 1980s, the World Health Organization helped Egypt to institute a schistosomiasis eradication program. Basically, the entire population received multiple IV injections to eradicate the disease. Now, unfortunately, this was before we knew about Hep C or of the importance of sterilization and not using shared needles. So Egypt had terrible sterilization practices and would often use the same needle on multiple people. As a result, this public health prevention program, whilst widely successful for reducing the rates of schistosomiasis, had the unfortunate side effect of infecting most of Egypt with Hep C. To this day, Egypt still has the highest prevalence of hepatitis C at a whopping 15% of the entire population. In a good news story, though, Egypt has since rolled out a Hep C eradication program, which has really helped to reduce these rates.
Wow, I'm not going to forget any of those stories. That's crazy. So we know you can get Hep C through blood transmission, inadequately screened blood transfusions, sharing needles, or poor healthcare equipment sterilization. Can you get it by having sex?
Sexual transmission is possible, although it's extremely unlikely at a rate of less than 0.002%, which is about 2 in 100,000. There's also the possibility of mother-to-child transmission during pregnancy, which is one of the biggest causes of childhood infection and the main reason why we care about hepatitis C in pregnancy.
So how big of a problem is hepatitis C? What's the prevalence in Australia?
Hepatitis C is present in about 1 to 2% of the population, including pregnant women, although this rate can be as high as 80% in high-risk groups.
What do you mean by a high-risk group?
So, great question. A high-risk group includes those who partake in IV drug use, sex workers, people in prison, those whose sexual partner is Hep C positive, patients with Hep B co-infection, or immigrants. Remember, the reason why immigrants might be at a higher risk is because of the higher chance of suboptimal medical equipment sterilization practices or the use of unscreened blood products overseas.
So what actually happens when you get Hep C? What are the symptoms?
Acute hepatitis C infection is actually asymptomatic in the majority of patients, meaning that most people with hepatitis C won't actually know they've been infected. About 20% of patients will develop symptoms of acute hepatitis, although this usually takes about 4 to 12 weeks for the symptoms to appear. Symptoms are generally mild and vague, and they include fever, nausea, vomiting, fatigue, muscle or joint pains, abdominal pain, reduced appetite, and weight loss. Jaundice, dark urine and pale stools occur in about 25%. Patients will also typically have deranged liver function tests. Following the acute phase, the infection may resolve spontaneously in about 10 to 50% of people. If it's left untreated, 85% will develop a chronic infection. This is defined as the presence of a detectable viral replication for at least 6 months. Most patients with chronic hepatitis C will experience minimal or no symptoms in the first few decades of chronic infection, although it can be associated with fatigue and mild cognitive problems. After several years, chronic infection may cause cirrhosis or liver cancer. Chronic hepatitis C has a 4% chance of hepatocellular carcinoma, a 20% risk of cirrhosis, and a 5% chance of death. Liver cirrhosis may lead to portal hypertension, ascites, easy bruising or bleeding, varices, jaundice, and hepatic encephalopathy. Hep C is actually now the most common cause for liver transplantation.
You might remember we mentioned before that Hep C also affects cells other than hepatocytes. Well, chronic Hep C infection can also affect the immune system and increases the risk of autoimmune diseases like Sjogren's syndrome, diabetes, and thyroiditis.
Okay, let's do a quick summary of what we've learnt so far. Hep C is a single-stranded RNA flavivirus that infects liver cells, causing hepatitis. It's a blood-borne infection that is transmitted through blood transfusion, shared needles, and poor sterilization practices. Sexual transmission is extremely rare, and mother-to-child transmission is an important cause of childhood infection. The prevalence of Hep C is 1 to 2%, including in pregnant women. In high-risk groups, the prevalence is up to 80%, and high-risk groups include IV drug users, prisoners, sex workers, those whose partner have Hep C, those with Hep B, and immigrants.
Hep C infects hepatocytes and can be asymptomatic in up to 80% of patients. 20% of patients experience symptoms of acute hepatitis 4 to 12 weeks after infection. These symptoms include nausea, vomiting, abdominal pain, jaundice, fever, fatigue, and myalgias. Liver function tests are typically deranged. If left untreated, 85% of patients will develop chronic infection, which carries a risk of cirrhosis, liver failure, and death.
So now that we know the basics of Hep C and why it's important, let's move on to the importance of hepatitis C in pregnancy. We'll start with screening.
In Australia, Hep C screening has been routine in pregnancy since 2015, with screening for high-risk women occurring since the early 2000s. We've all grown up with the phrase Hep B, Hep C, HIV, syphilis rolling off our tongue when we request antenatal bloods. So it might come as a bit of a surprise when we tell you that Hep C screening is not universal in every country. RANZCOG recommends universal screening for all pregnant women so that risk stratification can be performed and measures taken to both reduce perinatal transmission and minimise occupational exposure. Actually, they really recommend screening women before pregnancy so that women are able to make an informed choice regarding treatment prior to embarking on a pregnancy. Most countries and guidelines previously recommended a risk-based screening approach for Hep C in women of childbearing age. With these guidelines, only women with known and disclosed risk for Hep C, like IV drug users, a history of STIs, or unexplained chronic liver disease, were undergoing Hep C screening during pregnancy. In fact, even for a while there, Australia seemed to be the anomaly as one of the only countries offering routine universal screening for Hep C in pregnancy. ACOG only started recommending universal screening in 2020 in response to rising rates of Hep C in the US. The UK still doesn't include Hep C in their routine antenatal serology.
Wow, that is mind-blowing. All right, so let's talk through what we should do if one of our patients tests positive for hepatitis C. Let's say we're seeing Bella. Bella is a 35-year-old primary gravida who attends your clinic for antenatal care at 20 weeks. Bella has a troubled past with a history of IV drug use and incarceration for illegal sex work. She managed to turn her life around in her early 30s, and after a brief dalliance with a man with Hep C, she's now found herself working as a nurse. Bella comes to see you as you're going through her referral letter and you note that her hepatitis C serology has come back positive.
Poor Bella. After turning her life around, she still manages to get hepatitis C. Okay, so far we know that Bella has positive hepatitis C serology. Basically, that means that she has anti-HCV antibody. But can't Hep C antibody hang around for life? How do we know if she's got current hepatitis C or just a past infection?
So the first thing to do is to arrange a Hep C RNA. If the Hep C antibody is positive, but the Hep C RNA is negative, then this suggests either a false positive antibody result, a past cleared infection, or low-level viremia below the detectable assay level. You should keep in mind that Hep C RNA levels can fluctuate wildly during acute infection and may even become transiently undetectable. For this reason, patients with positive Hep C antibody but negative Hep C RNA should have the Hep C RNA repeated in 12 weeks to confirm the absence of infection. An important point to make here is that a person who has had a previous treated Hep C infection is not immune to Hep C. These people can still be reinfected, and so in patients with ongoing risk of infection, like ongoing IV drug use, for example, we should really be repeating Hep C screening in the third trimester. If the Hep C RNA is positive, but the Hep C antibody is negative, then this suggests acute Hep C infection. The Hep C RNA and anti-Hep C antibodies should be rechecked in 12 weeks. At this time, you would expect to see seroconversion, which confirms the acute infection. Persistence of Hep C RNA at 12 weeks indicates a high risk of subsequent chronic infection, whereas a negative Hep C RNA suggests spontaneous viral clearance, which again requires repeat Hep C RNA testing in another 12 weeks. If the patient is Hep C RNA positive and Hep C antibody positive, then this confirms Hep C infection. What it can't do is distinguish between acute and chronic infection. If there is documentation of a negative serum sample in the past 6 months, then acute Hep C is diagnosed. And Anne, what do we do now?
Well, the first step is to inform Bella of the diagnosis. We would explain that hepatitis C is a viral infection that predominantly affects the liver, and if untreated can lead to liver cirrhosis, liver failure, and hepatocellular carcinoma. It's also a curable condition, and so Bella would be reassured that since we've been able to diagnose a hepatitis C, we can also make sure she receives treatment. Hep C is a notifiable disease, and so upon diagnosis, the public health authorities are notified. This is important for tracking and monitoring of disease activity and identifying any outbreaks. We then want to refer Bella to a multidisciplinary team, including a hepatologist, infectious diseases specialist, and obstetric medicine. We should also arrange investigations, including hepatitis C RNA PCR for a viral load, liver function tests, and a liver ultrasound. Bella is also at increased risk of other infections, and so we should run a full STI screen, including hepatitis B, HIV, syphilis, chlamydia, and gonorrhea. You can also perform hepatitis C genotyping. Whilst it won't add much information during the pregnancy, knowing the hepatitis C genotype can help the treating physicians know a bit more about the prognosis and response to treatment.
Bella should be informed of the impact of pregnancy on her hepatitis C and the impact of hepatitis C on her pregnancy. In general, pregnancy does not tend to worsen the prognosis of liver disease due to Hep C. Hepatitis C does, however, have some impact on the pregnancy. The main risk we need to talk about is the risk of mother-to-child transmission.
So what's the risk of vertical transmission if a mother has Hep C in pregnancy?
The risk of mother-to-child transmission is about 5%. This increases to 15 to 20% if the mother also has a HIV co-infection. Remember, HIV and hepatitis C increase the risk of transmission of each other. Most cases of mother-to-child transmission occur at the time of birth. However, in 30% of cases, the baby develops hepatitis C antenatally from the infection crossing the placenta. Bella should also be made aware of factors that increase the risk of transmission of hepatitis C. So these include HIV co-infection, high viral load, IV drug use, prolonged rupture of membranes more than 6 hours, and invasive procedures like amniocentesis, fetal scalp electrode, and fetal blood sampling.
Interesting. So does that mean we should avoid amniocentesis in women with Hep C?
Invasive prenatal testing could theoretically increase the risk of transmission of Hep C by increasing fetal exposure to maternal blood. Patients should therefore be recommended to undergo the NIPT as part of their screening instead of the combined first trimester screen in order to reduce the chance of false positive results which require invasive testing. If invasive prenatal testing is indicated, amniocentesis is generally suggested over chorionic villus sampling. Ideally, you would avoid both tests. However, there isn't strong data to suggest that there actually is a high risk of transmission with amniocentesis. Patients who need amniocentesis should be counselled that data on the risk of transmission of Hep C is reassuring, but it is limited.
Apart from mother-to-child transmission, are there any other risks of hepatitis C in pregnancy?
Hep C infection is also associated with small for gestational age, preterm birth, caesarean delivery, NICU admission, and neonatal death. The increased risk of fetal growth restriction and other adverse pregnancy outcomes may be tied to the placental insufficiency that results from trophoblastic infection by Hep C. It has also been suggested that there may be an increased risk of adverse neurological outcomes like cephalohematoma, feeding difficulties, and neonatal seizures, although this is still being studied.
The other thing we need to be aware of is the increased risk of intrahepatic cholestasis of pregnancy. Hep C increases the risk of ICP, and the risk of cholestasis occurs at a much earlier gestation. In patients who present with itch and Hep C, you should always be alert to the possibility of intrahepatic cholestasis of pregnancy.
Okay, and then we want to treat the Hep C, right?
Unfortunately, Hep C cannot be treated in pregnancy. When I was studying for exams, we would quote pegylated interferon and oral ribavirin as the standard treatment for Hep C and mention that because these medications are teratogenic, they are not recommended in pregnancy. These medications work by stimulating the host's immune system to clear the virus. They take a long time to work, are associated with horrible side effects, and are often ineffective. Since then, there have been several advancements in the treatment of hepatitis C, and we now have access to direct-acting antivirals. Direct-acting antivirals work by targeting proteins of the virus and interfering with viral replication. Direct-acting antivirals work by targeting proteins of the virus and interfering with viral replication. Direct-acting antivirals are highly effective, well-tolerated, and administered orally. They really have revolutionized the treatment of hepatitis C. Unfortunately, these drugs are currently contraindicated in pregnancy due to a lack of safety data. However, there are some studies into the possibility of antiviral treatment during pregnancy which provide promising early safety data. A few clinical trials are underway looking at different types of antivirals in pregnancy, most notably the HIP-2 study, the STORK study, and the IMPACT study. The benefits of this will be enormous since a large proportion, and by that I mean more than 90% of women who are diagnosed with Hep C during pregnancy, actually don't start treatment within a year of delivery. In the meantime, treatment of Hep C can begin after birth and the completion of breastfeeding. Treatment is very effective, resulting in clearance of the virus in up to 80% of cases. Remember, without treatment, 80% of women will develop chronic infection, and so it's really important that these women are followed up and receive treatment as soon as they can.
Is there anything we need to do differently in the pregnancy?
Well, apart from avoiding amniocentesis if possible, there really aren't any additional steps to take in the antenatal period. There's nothing else we can really do to reduce the risk of antenatal vertical transmission. Most of our efforts are focused on reducing the risk of mother-to-child transmission at birth. The main thing we do is to minimise the use of fetal scalp electrodes and fetal blood sampling where possible. The use of a fetal scalp electrode is associated with an increased risk of hepatitis C transmission. However, if internal monitoring is unavoidable, for example, when you can't get a fetal heart rate with a Doppler and the alternative is to proceed with a caesarean section, then you may consider applying an FSE in consultation with the woman.
Other considerations in labour include avoiding prolonged rupture of membranes and an episiotomy, which are both associated with an increased risk of Hep C transmission. Expectant management of ruptured membranes at term should be avoided, and active management with Synto should be recommended immediately. There's not enough data to say what we should do with PPROM, and so management of PPROM is no different in patients with Hep C. Ideally, we should also avoid early amniotomy where possible.
Now the big question, should women with hepatitis C be advised to have a caesarean section?
Definitely not. There's a lot of evidence to suggest that a caesarean section does not reduce the risk of perinatal hepatitis C transmission. There is also lots of evidence to suggest that caesarean section also doesn't increase the risk of perinatal transmission. The mode of delivery should be based on obstetric indications, and vaginal birth is definitely not contraindicated.
What about after the baby's born? Is it okay for women with Hep C to breastfeed?
Breastfeeding is generally recommended in patients with Hep C. Although Hep C RNA can be detected in breast milk, it contains much lower levels of HCV RNA than blood. The viral activity of Hep C is also reduced by the free fatty acids in breast milk, and it is thought to be inactivated in the infant digestive tract. Many studies have demonstrated that Hep C positive mothers can safely breastfeed their babies. Now, the caveat to that is where the mother has bleeding or cracked nipples. In these circumstances, breastfeeding should be avoided and the milk from that breast should be discarded.
In general, babies do not require any treatment at birth. It's a good idea to wash the baby before administering any IM injections, like the hepatitis B vaccination, vitamin K, or RSV immunisation, in order to minimise the risk of transmission at this time. HCV RNA testing should be done at 3 months. Remember, the majority of cases of neonatal hepatitis C occur at the time of birth, and it can take up to 12 weeks for the RNA to become positive, which is why we don't routinely test babies at birth. If the hepatitis C RNA is positive at 3 months, then the baby should be referred to a paediatrician and infectious disease physician for management of hepatitis C. If the HCV RNA is negative, the baby should be tested for HCV antibodies after 18 months to demonstrate passive maternal antibody clearance. If HCV antibodies are still present at 18 months, then you should check the HCV RNA to exclude hepatitis C infection, or repeat the HCV antibodies at 24 months to ensure clearance of maternal antibodies. Hep C antibodies cross the placenta and thus are present at birth. These antibodies persist in 15% of infants at 12 months and 1% of infants at 24 months. The vast majority of infants will clear maternal HCV antibodies by 18 months, and so this is the reason why we test for HCV antibodies after this time. Testing performed any earlier might be a false positive due to the presence of maternal antibodies. In babies with acute hepatitis C, about 20% of babies will clear the virus by 15 months, but 80% will go on to have a chronic infection. And this is why it's important to detect and treat these babies.
All right, well, that wraps up this week's episode on hepatitis C in pregnancy. Let's summarise the key points. Hep C is a single-stranded RNA flavivirus that infects liver cells causing hepatitis. It's a blood-borne infection that is transmitted through blood transfusion, shared needles, and poor sterilisation practices. Sexual transmission is extremely rare, and mother-to-child transmission is an important cause of childhood infection. The prevalence of Hep C is 1 to 2%, including in pregnant women. And in high-risk groups, the prevalence is up to 80%. High-risk groups include IV drug users, prisoners, sex workers, those whose partner has Hep C, those with concurrent hepatitis B, and immigrants.
Hepatitis C infects hepatocytes and can be asymptomatic in up to 80% of patients. 20% of patients experience symptoms of acute hepatitis 4 to 12 weeks after infection. Symptoms include nausea, vomiting, abdominal pain, jaundice, fever, fatigue, and myalgias. Liver function tests are typically deranged. If left untreated, 85% of patients will develop chronic infection, which carries a risk of cirrhosis, liver failure, and hepatocellular carcinoma.
Hepatitis C can be transmitted to the baby in utero or at the time of birth. The risk of mother-to-child transmission is about 5%, and this risk increases to 15% if the woman also has HIV. Factors that increase the risk of transmission include HIV co-infection, a high viral load, IV drug use, prolonged rupture of membranes, and the use of invasive procedures. Hepatitis C also increases the risk of intrahepatic cholestasis of pregnancy at an earlier gestation.
Hepatitis C is screened for antenatally with the booking bloods. If a woman tests positive for Hep C antibodies, the diagnosis is confirmed with a Hep C RNA to quantify the viral load. Additional investigations should be arranged, including liver function tests, a liver ultrasound, Hep C RNA, STI screen, and Hep C genotyping. The patient should be referred to a multidisciplinary team, including hepatology, infectious diseases, and obstetric medicine.
Hep C treatment is highly effective but is currently contraindicated in pregnancy. Pegylated interferon and oral ribavirin result in 50 to 80% clearance of the virus, but unfortunately the medication is teratogenic and is not recommended in pregnancy or breastfeeding. Direct-acting antivirals are even more effective for Hep C, but they are currently only being used in pregnancy as part of trials. Treatment for Hep C in pregnancy should be delayed until after birth and the completion of breastfeeding. Importantly, a woman should not conceive for 6 months after treatment due to the teratogenic risk of the medication. Good contraception should be provided for women undergoing treatment for hepatitis C.
Steps to reduce the risk of mother-to-child transmission include avoiding amniocentesis where possible, avoiding early amniotomy, avoiding prolonged rupture of membranes, avoiding FSE and fetal blood sampling, and avoiding episiotomy. Caesarean section is not recommended, and breastfeeding is fine as long as there's no cracked or bleeding nipples. Postnatally, the baby should be washed before receiving an IM injections. Babies are tested with HCV RNA at 3 months and HCV antibodies at 18 months. Positive results should be referred on for treatment.
So thank you for listening to this week's episode of the Uterine Sound podcast. You'll find our summary slides on Instagram later in the week. Check out our website, www.theuterinesound.com, email us at theuterinesound@gmail.com, and find us on socials at The Uterine Sound. Until next week, hepatitis, see you later.